All right, everybody. Welcome to the CNS Journal podcast. This is the June 2022 edition. Today, a little bit of a special guest with Justin Moore from my same institution that will be talking about his paper on safety and efficacy of off-label use of pipeline embolization device. And this is based off of the 2018 FDA Approved Indications for Intracranial Aneurysms. And so we'll review the single center retrospective study. And as a guest, we have Dr. Peter Kahn from UTMB, who's we're very lucky to have him, very expert in this subject. And then we also are introducing our CNS fellow, Haydn Hoffman. And so that'll be the group. So we'll start off by introductions. And Justin, would you like to introduce yourself to the group?
Absolutely. Thank you, Raf, and thanks for inviting me here. It's a pleasure to talk about this sort of paper with such esteemed colleagues. So I'm looking forward to it. I'm a cerebrovascular surgeon, skull-based surgeon at BIDMC in Boston and faculty with Harvard Medical School. And, you know, I do a lot of clinical work and I also like the research side of things like many of us.
Excellent. Thank you. And then again, we'll have Peter introduce himself.
Hi, I'm Peter Kahn. I'm a cerebrovascular neurosurgeon from Texas, from UTMB, and I have a special interest in flow diversion. And fortunate to know everyone on the call for a long time already.
Excellent. And then last but not least, Haydn.
Hi, everyone. My name's Haydn. I'm a sixth-year neurosurgery resident at SUNY Upstate, interested in cerebrovascular and endovascular neurosurgery.
Great. Again, excellent choice today for a discussion. So Justin, go ahead and give us the brief introduction and tell us a little bit about this paper and, you know, some of the results, et cetera.
Sure. So basically, the paper looks at a pipeline, which is a type of flow diverter for those maybe not in vascular all the time, which is a type of device that we use to treat aneurysms. It's a relatively new device. It's only been around for the last decade, but it's got a lot of traction because it works so well. And I suspect we're all fans of it here. And really, the sort of inspiration for the paper is it has certain indications that were, identified in the original trials. But the question is, how far can we push the technology? We've all seen aneurysms that are very difficult to treat. And, we sort of tossing, open surgery, clipping versus stent coiling versus coiling alone. And now flow diverters are in the mix. And so the question is, do the flow diverters are they useful off-label? So it's about expanding the indications. And what we've found is at our institution is we've actually used it off-label quite a lot. And I suspect Peter has as well. And the question here really comes down to, is it safe to use off-label? Should we be doing it more? Should the indications actually expand? And, what is best practice in treating some of these difficult aneurysms? So I think the paper aims to get at that. And so what essentially we looked at is a cohort. We have a large cohort of flow diverter treated aneurysms, in the order of sort of over 400. And we looked at we basically divided the cohort up into two groups. Those that were treated on label according to the 2018 indication, which is the most recent update of the label. So there is a previous, there was previous label which was updated in 2018. We actually looked at the latest one, and then we had one group of patients who actually were on label, and so this is a straight chip shot basically. And then we looked at all the patients that were off label. So these are patients that don't typically come under the standard characteristics of a patient getting a flow diverter. But, in the case, we thought this was the best option. So we wanted to see how these patients went. And so we had, probably not unexpectedly, we had 321 patients in the on-label group. And then we had 171 in the off-label group. And basically, we wanted to do a comparison to see, how do these patients go? Is it reasonable to be doing these? Our gut instinct was it was, but also, what are the issues with it and how can we mitigate that? So it was also investigating, because if you're going to expand their indications, then you need to sort of know, what are the problems with it? So you can have a meaningful conversation with the patient about the pros and cons, of this option. And so we did that, and it actually provided quite a lot of insights. perhaps most importantly, it actually works very well. We didn't find it's quite as effective as the on-label, but it's very close. It's upwards around the 80% mark, which, was great. So that gives us, if people want to use it for off-label indications, as we described in the paper, then, this gives you, good evidence to go forward with that, because it actually did work in our hands very well. However, it wasn't all sunny days. So not only did it not work quite as well, although, pretty well, there was some extra complications, particularly, surrounding things like using it in ruptured aneurysms. And you can see the mix coming up when we talk about using it in a ruptured aneurysm. You have to put patients on dual antiplatelets. There's a bit of a tension there. And so what to do about that, and how do those patients go, and what are the risks to consider if you get a patient that you think, I really want to put a flow diverter in here, but it's off label. Should I be doing this? And how to have a chat with your with the family or the patient about that. So that was that's sort of the core. Some of the questions I'm sure we'll get to will sort of dig into some of those results, but that's essentially why we did it.
Excellent. Thank you for that wonderful introduction, Justin. So we'll kick it off to Peter to ask any questions.
Sure. Really fantastic study, Justin. I just wanted to kind of follow up with where you left off about the rupture. I think one of the big group is the rupture group. So I just want to see you and Rafi, like what is your protocol to minimize the problem that comes to doing therapy? Because obviously, like, we're trading from embolic issues for not using it to kind of issues with hemorrhage and hemorrhagic issues. So for example, when and do you place EVD up front, and when do you do the loading, or how do you load? Do you do oral load? Do you do intravenous load in the procedure? And I think also Haydn, I think, mentioned his question about kind of like the neuro coded device or device or service modification. So I think it's a bit of a kind of a greater question. I think we want to hear about, like a protocol and minimizing complication, and also your thoughts about the newer devices in terms of that.
Well, I think you've really zoned in on one of the big controversies, right, and issues that we face as cerebrovascular neurosurgeons, and particularly using the shield. And so in our practice, so there's a few components. If we if we get a ruptured and we image and it looks like it would be good for flow diverter, we're quite aggressive with EVD drainage. So that's the first thing, because we want to have it in before we put anyone on dual antiplatelets. So if there's any suspicion of that, then the EVD goes in early, because it's much more difficult and risky if it goes in later. So we have a low threshold for that. We don't wait and see. If it looks like, we're a bit plump, there's a lot of blood in there, it's a Fisher 4, we will put it in. Yeah. Then the second question about how we treat them. So we tend to use Brilinta or ticagrelol, and the reason why we do that, so we load with 180 milligrams, and we basically load as soon as we think this is going to need a flow diverter. Ideally, by the time you sort of get everything ready, it's been going for half an hour, the longer the better, basically. So we get it in early up front. If the patient's unconscious, we deliver it through NGT, and if the patient is otherwise okay, then we just do it orally as sort of standard. The reason why we use the Brilinta is in our cohort, and you can see this in the paper as well, we had about only 56% of patients actually responders to Plavix. So at least in the group of patients we're treating, if we just went with Plavix, there's going to be a lot of non-responders. And so that's why we've sort of jumped for Brilinta as our first line intervention. And so once we...
Sorry, sure. Go ahead. Sorry. Just to clear for the group, you also load aspirin too, right? Just to clear for the group, you load both aspirin and Brilinta.
Yes, they all get aspirin for sure. Okay. Absolutely. And then following on from once they've been loaded, then we go on for Brilinta. We do the 90 milligrams BD, and then we have the aspirin, the 364 milligrams, and we generally carry that on for at least 3 months. And then if all's well, we try and wean off the Brilinta and keep going with the aspirin, which I think is pretty common and pretty standard. The other thing I would say about using Brilinta is it has a relatively fast offset. And so if you do need to put a shunt in or something like that, it gives you an option there to, to sort of hold for 24 hours, put the shunt in, and then start it again if that's necessary, which is a bit quicker than Plavix. So that's another, another possible benefit of using Brilinta. With the second part to the question about the pipeline shield, so I have to say up front that we did not have any patients in this cohort. We excluded shield patients. So this is just the flex and previous versions. I have to say now we basically only use shield. And so, I think this is, it's an exciting development. The issue, of course, is that, they still recommend using dual antiplatelets. And so it's one of those things that even in a rupture at the moment, we tend to use dual antiplatelets and, hope for the best. If data comes out saying it's safe to avoid that, then obviously in a rupture case, that would be great. But I don't think that data is available yet. So, we tend to, we're sticking on label basically in terms of the recommended treatment with shield. But I think there's a lot of opportunities for that. And I think over time, there'll be enough cases that come out, for people that really couldn't be treated with dual antiplatelets that, we'll get a sense of how safe it actually is.
I think, Justin, the interesting thing is that we all kind of have that thought. When I recently looked at the literature for that, I think it's interesting because, for example, whether that be pipeline with the shield technology or the FRCSC, these device source modification, if you look at the in vitro data in the flow loop, it's certainly less thrombogenic than the previous generation devices. But when you look at the larger clinical studies, for example, for the shield, you look at the shield study or the PFLEX studies from Europe. Interestingly, that the occlusion rate and the thromboembolic rate is not that different than the flex on dual antiplatelet therapy. So this is one thing. It doesn't seem like they're, even though in vitro cases sounds great, but in clinical studies, like these kind of prospective adjudicated studies, that the thromboembolic risk is still there about 3%. So I think there are a few studies from Europe that did that. And then in terms of the single antiplatelet therapy issue, we don't have the P48 and P64 in the US, but if you look at, there are a lot of studies, kind of smaller studies, smaller case series from Europe, to look at the issue of single antiplatelet therapy. And it shows that thromboembolic risk is actually quite high when you just use one agent. In fact, I think for the flex, there's one Australian study from Manning, that
yes,
they have like a 7%, risk of thromboembolic complication, from aspirin therapy alone. So I think like you say, if we have to do it, it's probably theoretically better, but I think the data certainly to this point in my mind have not borne out yet. So I think, kind of what you do is like, I think it's perfectly like the standard of care to date is used to antiplatelet therapy, even in rupture cases. Rafi, what do you think?
No, I agree with you, but good thing is that I kind of defer more of this work to like Dr. Ogilvy and Justin, honestly. I kind of focus more of my work on tumors. And so at the end of the day, I agree with what we found in the paper, but I don't really do any of this on my own practice.
I would just make a point too that the single agent studies, especially that one from Australia, that was also drawn from they used databases that covered the whole country, and so they only got like a handful of patients, and so you can see that even in that circumstance, it's pretty rare. There's very few people that are going, and chancing that at the moment. Yeah. So I think it's sort of a very interesting area, and I'm sure it's going to develop. But at the moment, I think that our overall feeling, the safest way is to still go dual antiplatelets at the moment.
I think that's why it's great about these podcasts. It's more of like a discussion kind of forum, and I think kind of from experience standpoint, I think the dual antiplatelet therapy, if we do it safely, like the way you do it early EVD, kind of close to the procedure kind of loading, right? The IV oral. I mean, I think is quite safe, right? I mean, it's really hard for us to imagine not using that, and when you're putting something high metal coverage in the patient. So just as interesting discussion for sure. Haydn, you have any questions you want to bring up?
Yeah, so thanks. I just want to congratulate Dr. Moore, the rest of the authors on this. It's a really outstanding study, and I think it highlights, a subset of aneurysms that are often very difficult to treat, and oftentimes there's no good open surgical option or coiling option. So I think this is a really important study, which is why I selected it. One of the interesting things I noted was that the thromboembolic complications were occurring in a more delayed fashion in the off-label group. I think it was a median of about 55 days post-op versus like day 0, basically immediately after in the on-label group. So I was wondering if you thought that these off-label aneurysms might merit a different follow-up or a different dual antiplatelet duration. I know you were doing 3 months typically for dual antiplatelets. So I was just wondering how that has changed your practice at all, if it has.
Yeah, that's a great question and a nice insight from the paper. So I'm glad you brought it up. Look, so to answer, firstly, yes, we have changed our practice. We actually, with off-label aneurysms, we often keep it going for 6 months. The dual antiplatelets rather than 3 months. So that's something to note. And the reason why we have done that is, we found, the data that we have these delayed problems. And what we feel is a lot of the off-label, we're dealing with smaller vessels. So a lot of the, extending out, or they already have something in there, a stent or another flow diverter or something like that. So you're narrowing the vessel further. And so what our theory is the further you get out and the smaller the diameter of the vessel, you're having slower blood flow. And part of the problem we think is that once you slow down the blood flow, it's less forgiving. If there's any metal there, when the blood's moving a lot slower than, say, through the ICA, then it can clot off. So we think that part of it is it's just like, it's not forgiving, and you really have to have the whole device endothelialized before you can safely come off. And whereas you get the feeling that even though most devices get there in 40 days or whatever, in the ICA you may have a few little holes, but the blood's rushing past, so nothing's adhering to the metal and causing the clot. Whereas if you've got a much slower velocity, then if you've got those same holes, then you get a problem. So I think we have changed the practice to actually extend, especially when the off-label is because it's in a smaller vessel, like the A2s or the P3s, those sort of things. And we've found that we're still collecting data. That will be a paper for probably a few years' time, but we feel that there is less issues. So it's something that we've changed, and I encourage others who are particularly going for the smaller caliber vessels to have a think about that. It may be helpful.
And I assume you're doing a catheter angiogram at 6 months, and then based on that you decide, or
no. So what we do is we do an MRA at 6 months and have a look. The reason is we have a previous publication that we found. I think it's in neurosurgery too. We looked at all our flow diverters, and we realized that it's sort of, a lot of them aren't, the aneurysms are patterned still at 6 months. Mm-hmm. And we realized that we weren't doing anything. All we do is get one at 6 months and then get another angiogram at a year. And so what we've done is to try and minimize how many angiograms the patients get. We've just shifted to 1 year. So we get the MRA at 6 months just to check, and usually it's fine, patient's fine. But then the 1 year one is the critical one to assess. It'd be nice to get a 6 month one just to look, but angiograms, even though they're very safe, they're not 100% safe, and so we try and minimize that. So we don't get one at 6 months. We do get one at 1 year.
Peter, is that something you do as well?
Yeah, I totally agree. And if you look at all the studies, they define success or failure at really at 1 year anyway. So if it's 6 months, if it's open, you're going to say, well, don't worry too much. We'll do another one. I guess the only nice thing is if it's close, you may, but I think the MR is very good. I think the MR serves that purpose, for sure. But so I think the control angiogram it's good.
It's sort of interesting too, because before we looked at ours, like this maybe 6-7 years ago, we did a survey. You may even filled it in for us, Peter. But we of this CV section, we surveyed for their follow-ups because there was no routine stuff, and it was unbelievable, the variety. Like as many hospitals, there was a different follow-up. So I think it's one of those things that it's slowly converging, but it definitely takes time, and which is understandable. You got to get experience, right?
Yeah, I think this makes perfect sense. When we start technology, you want to check early. I remember when we first started doing pipeline, It's used to check even on day one and then 1 month, but now, like you say, we know that you don't even, think about retreatment to at least 1 year. So, so probably there's no point to subject someone to an invasive procedure before then, especially when you have good alternatives to assess the situation.
Absolutely. Totally agree.
Yeah, it's just maybe another question for you. So we're talking about different kind of off-label cases. Rupture is one group. Then there are other groups like types of aneurysms and locations. So how about type of aneurysms in terms of bifurcation aneurysms? What kind of bifurcation aneurysms would you clip, versus stent coiling versus flow diversion? I guess maybe what kind of bifurcation aneurysms would you go to flow diversion, or is that like the last resort for that?
So we're still a pretty big clipping practice. So we actually, about 30% of our cases we still clip. And so I would say posterior circulation bifurcation, we generally would pipeline or stent coil depending on the anatomy. And I mean, of course, we all, it's patient specific, aneurysm specific, but in general, the ones that we tend to clip, we definitely do a lot of MCAs still. We find that clip reconstruction often gives us a superior result to what we think we can achieve with endovascular. And also ACOMs. We clip a reasonable number of ACOMs. I would say it's not quite as much as the MCAs, but it's up there because, if you need the right sort of morphology. And, even though we sort of routinely cover branches with pipelines, I'm sure everyone has that case where they did it and they didn't get away with it. It might only be, 1 in 100, 1 in 200 cases, but there's just that, that occasional one that for some reason the flow dynamics, you lose the branch and it's, even if the patient does all right, it's very disappointing, right? So we do tend to use clipping a lot, but I would say that anything in the posterior fossa, we generally would be looking for an endovascular solution there, and that's often pipeline or stent coiling, depending on the circumstances of the case. MCAs, it's more often clipping and occasionally a pipeline or a stent coiling, depending on the anatomy, or if the patient's been treated with clipping already, which is rare, but then there's some residual or a second aneurysm develops because, some of the patients we've been tracking in our practice for 25, 30 years. And so, they actually develop new aneurysms, which can be very close to where the clip was. And you just, you think there's going to be a lot of scar tissue and difficulty getting it. So in those patients, we tend to go, again, a bit more towards the endovascular, but generally pretty clip happy there.
So I guess, Justin, anterior circulation, ACOM, MCA, mainly clipping. In posterior circulation, do you prefer stent coiling and bifurcation aneurysm before flow diversion in general?
I would say it's a little bit on the specifics of the case. I would actually say if it's an elective, we often do flow diverter. Okay. We found that works pretty well. If it's a rupture because of the dual antiplatelets, then we're more of a stent coil, procedure. So, but we've put a lot of especially if there's sort of you think you can get the angles right. We've put a lot of flow diverters from the basilar into the P1. And, sure. We haven't had too many problems with that. I mean, it's not risk-free, but we tend to do that quite frequently. We haven't had a huge issue.
Great.
Very nice. Any last questions, Haydn, on your end?
Yeah, that discussion actually kind of led into my last question, which has to do with one of the limitations of endovascular therapy, which is recurrence. And a lot of the off-label treatments were retreatments. So I was wondering if you anticipate more upfront use of flow diversion for some of these off-label aneurysms based on the positive results of this study.
Yeah, thanks for that. That's a great question. I would, I think it's one of those things, again, because we have quite a mature practice. With some of my colleagues, we some of these patients were treated 25 years ago. They didn't have any of the endovascular equipment, so that's one reason why we see a decent number of retreatments. And I think it's you've got the adoption curve or the innovation curve. It's sort of that S shape. And I think what we find is that when we have a really difficult aneurysm because they're already being treated, you're looking for the options, and you're like, you don't want to clip because it was already clipped, or there's already a stent coil in there. And so even though the flow diverter is off label, it's still the best option for that. And so you use it, and then, with the results of this study, I think it sort of brings us to being more confident that we could use it up front, in the same situation. We don't have to have, well, it's this type of aneurysm, but the clip and then make clipping difficult, so we wouldn't clip it. And so we'll use the flow diverter, but if it didn't have the clip on and it was a de novo, then we would clip it. Well, now we might switch to and we've seen this in our practice, we start to experiment and say, well, I think a flow diverter would actually do well here. And so I think it does shift us forward. And so I think the positive results of the paper, certainly shifting our practice. It's a sort of, it's a slow movement, but it gives you confidence that if you've got a really good result in spite of the difficult circumstances of a retreat, then you're going to get hopefully great result when you have a de novo aneurysm. So I think it gives you the confidence to move into those off-label areas and say, you can tell the patient, look, we've got great results here, so this is an option, and if it is appropriate, then you can do it.
Well, thank you so much.
My pleasure.
Yeah, and I think that kind of brings us to our time. So, I just want to thank you again, Justin, for, presenting the topic and awesome paper. And of course, Peter and Haydn for your questions and insight. I think this was very, very, very useful. And so I just want to remind the listeners that this is CME activity, and that the Journal Club podcast, or the CME, is complimentary to all CNS members and is worth 1.5 credits. So again, thank you, everybody, and we'll obviously see you next month.